We work to create a world
that's free of infectious diseases.
We work to make sure
that no infectious disease
is left unchallenged.
We discover, develop,
implement and evaluate
health solutions,
working alongside the most at-risk communities.
Doing so ultimately builds
a healthier, safer world for everyone.
We are the Kirby Institute.
Hello everyone and welcome to today's Kirby Institute seminar series. So my name is Ben Bavinton and I'm from the HIV Epidemiology and Prevention program here at the Kirby Institute and also the chair of the seminar series. So of course I'd like to begin by acknowledging the traditional custodians of the lands on which we all gather here today and pay my respects to their elders past, present and emerging. So for me, this is the Gadigal people of the Eora Nation. And I extend that respect to Aboriginal and Torres Strait Islander peoples joining us today. And I encourage each of our speakers to acknowledge the country that they are on to before they start speaking. So just some housekeeping to start off with. The format for the seminar today will start off with 3 presentations, followed by a Q&A session at the end. So you'll be able to ask questions throughout all of the presentations by clicking on the Q&A icon at the bottom of the screen and just posting your question. So our presenters today are Carolyn Murray, Matthew Vaughan and Andrew Grulich, and I'll introduce each speaker just before they speak. So moving on to our first presenter. So Carolyn Murray is the Director of Public Health Programs, Centre for Population Health at the New South Wales Ministry of Health. Carolyn has worked in the area of HIV and sexual health since 1993, both as a registered nurse, a health promotion officer and a manager. Carolyn's current portfolio undertakes policy and implementation in the areas of tobacco, HIV, sexually transmitted infections, and hepatitis. So please welcome Ms. Carolyn Murray. Thanks.
Good afternoon, everyone. Firstly, as well, I'd also like to acknowledge the traditional owners of the land on which we're on today. I'm on the Gadigal land of the Eora Nation. We honour the ancestors of yesterday, the custodians of today and those of tomorrow. We recognise the continuing connection to the land, the waters and how culture is held, nurtured and shared. We pay our respects. So today I'm doing the Ministry of Health part of the presentation. So my name is Carolyn Murray and I'm the Director of Public Health Programs at the Centre for Population Health at the Ministry of Health. I've been in this role now for a couple of years and we were really hoping for this presentation today that Heather Marie Schmidt would be able to present, and a lot of you on the session today would know her, but she's working very hard at the moment for UNAIDS responding to the COVID outbreak in the region. So I'm delighted to be presenting, but also our thoughts out to the region and the work that she's doing today. I'm going to give you a presentation on the policy environment and the actions that guided EPIC New South Wales and that allowed it to become such a major success for New South Wales. I'll provide a background on HIV in New South Wales before EPIC. I'll highlight the importance of the HIV strategy for 2016-2020, and I'll discuss the role of New South Wales and that they played, and the role that the partnership played as well. But before I start, I really just want to emphasise the amazing example of partnership that this project holds between the clinicians, community, academia and government. Everyone had an important role to play and we couldn't have done it without you. So to everyone on the session today as well. I'll give you some examples of how things have been done differently. And then at the end, I'll acknowledge the other colleagues that were involved. So before the introduction of PrEP in 2016, HIV diagnosis in New South Wales were not improving. By the end of 2012-2015 strategy, the decline in new HIV diagnosis was modest. But despite comprehensive community mobilisation, increased HIV testing and treatment uptake. So overall diagnosis was stable, they weren't declining. New South Wales was only approaching but not quite meeting the UNAIDS goals of 90-90-90, and condoms and treatment as prevention as HIV were not really enough, and it was clear that something needed to change. PrEP was the missing piece of this puzzle. International evidence pointed to PrEP as an appropriate option for those at high risk of HIV. PrEP was known to be effective, but it was not licensed in Australia. Local demonstration projects such as the Prelude study showed high adherence and 0 HIV infections. So the community organisations, academics and government got together and agreed that a rapid rollout of PrEP combined with high HIV testing and HIV treatment was a toolkit that was needed to see this rapid decline that they were wanting to see in HIV infections. So on December 1, Minister Gillian Skinner announced funding for EPIC New South Wales, a statewide large-scale implementation of the PrEP trial to commence recruitment by March 1, 2016. In the New South Wales HIV strategy 2016 to 2020, we set an ambitious target to virtually eliminate HIV transmission in New South Wales by 2020. This set the expectation that rapid reductions in HIV were the target and that business as usual just wasn't really going to cut it. There was a real commitment from the very top to drive down HIV infections. The Minister for Health, Gillian Skinner, and of course the now very well-known Kerry Chant provided leadership to enact this real change. The commitment to the strategy allowed significant New South Wales health resources to be reprioritised and mobilised and to deliver a large-scale impact project. Apologies. Let me go. Getting PrEP out to those who needed it most was the most important thing that we could do. So how are we going with the rollout? So modelling from the Kirby Institute suggested rapid reductions in HIV could be achieved at the population level by targeting high-risk gay men, achieving high PrEP coverage, rolling PrEP out quickly, so that meant in 1 to 2 years. And we wanted to get as many high-risk gay men onto PrEP as we could and as quickly as we could, not only to protect the individual, but also to achieve a herd immunity protection across the community. EPIC New South Wales is a beautiful example of true partnership, and you can see the friendly folk there are standing much closer than they probably would be today. And we formed a coalition of clinicians, academics, community organisations and government. The partnership was a fundamental part of EPIC's success. EPIC New South Wales was a real-world implementation trial. The trial was designed to utilise resources and infrastructure that we already had to increase access to PrEP. The ministry communicated directly with their local health districts to stress the trial's importance at every site and to garner support from the chief health officers, the chief executives of the local health district. All sites were set an ambitious enrolment target with direction to commence enrolment on March 1, 2016. I want to acknowledge the responsiveness of the local health districts and the sexual health services in preparing their clinics to implement EPIC New South Wales. Our doctors and nurses and private GP practices should be applauded for their efforts. The ministry committed a modest amount of additional costs with the implementation research to enable the measurement of PrEP's effectiveness, both at the individual and statewide level. EPIC New South Wales was one of the largest PrEP implementation trials globally. It exemplified a strategic approach to the scale up and evidence-based interventions and how rapid implementation across services can be achieved through a strong partnership between the system managers, clinical services, researchers and community partners. So what was the ministry's role? The ministry secured a deal with Gilead to provide the study drug for free via donation. In the later phases of the study, the ministry procured drug from Mylan. The ministry led the clinical trial labelling and worked to distribute the drug to all the recruitment sites across the state. Kerry Chant, our Chief Health Officer, supported the reorientation of services to allow nurse-led dispensing, and this was huge. There was a significant change that meant PrEP could be dispensed to participants in a rapid, low-cost and sustainable way. The model was implemented successfully in public clinics in most of the local health districts with widespread support and no serious safety effects. The ministry also provided peer-based registrations and importantly made a commitment to continue to provide PrEP to participants until either PrEP became available on the PBS, the cost of PrEP fell significantly, or that all study drugs had been allocated. Coverage was key. The ministry wanted to ensure that PrEP was accessible to anyone who needed it, not just those in the gay bubble of Darlinghurst, but throughout New South Wales. We worked with sites to ensure there was sufficient stock and participants wouldn't run out of medication at any point. This involved a lot of juggling and negotiation between sites. The demand was high, and we'll hear from later from ACON to talk about how this was achieved. Enrolments into EPIC New South Wales were exceeded almost immediately. Kirby Institute calculated that PrEP intervention expanded to 3,700 high-risk men for the period of 2 years could see a dramatic decline in HIV in New South Wales, HIV transmissions across New South Wales. The 2-year quota was filled within the first 8 months. New South Wales HIV notification data shows that it was starting to work, and in June 2017, New South Wales reached a record low number of new HIV cases in a 12-month period. It soon became clear that the demand was very high and that the ministry supported the expansion of the study to ensure that all people at high risk of HIV, according to those guidelines, didn't have to have any pause in the recruitment or the access to the drug. We worked to ensure that there was no break in PrEP supply for existing patients until PBS was listed for the PBS listing of PrEP. With our goal of virtual elimination in New South Wales in sight, despite uncertainty from PBAC, the decision was made to commit additional funding and to provide PrEP across New South Wales until there was another funding mechanism. This is the home stretch, and this enabled us to prepare the New South Wales health system for PrEP through engaging as many clinicians as possible, communicating with our stakeholders, continuing to build the relationships and seeking out those hard to reach patients. I'll save it to Andrew to present on the results of EPIC. To conclude, the policy environment and actions that guided the EPIC New South Wales success was having a clear objective. We wanted to get PrEP to as many people as we could, as quickly as possible. We had tremendous support from the former Health Minister, Gillian Skinner, and from the Chief Health Officer and the current Chief Health Officer, Kerry Chant. There was an amazing partnership that formed between clinicians, government, community, and academia. We were all able to reorientate services and establish a nurse-led model of care. And we had a unified statewide approach, providing equitable access. Above all, there was a real willingness to do things differently. In closing, I just really wanted to acknowledge everyone that's been involved from the beginning, and some of those still working at the ministry, but not all of them. So obviously the Minister Skinner, who's since retired, Mr. Andrew Kirk, who was the Chief of Staff at the time, Mary Foley, the Secretary of Health at the time, Dr. Kerry Chant, who's our current Chief Health Officer, Dr. Christine Selvey, who is still currently in the ministry and working on COVID, Joe Mitchell from the Centre for Population Health, Daniel Madadu, Joe Holden, Heather Murray Smith, and Dale Halliday. Thank you very much.
Thanks very much, Carolyn. That was great. So we'll move on to the next speaker now, who is Matthew Vaughan. So Matthew is the Acting Director for the HIV Sexual Health area of ACON, and he's ACON's Principal Campaign Planner, where he leads strategy and development of the multi-award winning campaign Ending HIV, which seeks to end HIV transmission in New South Wales. So please welcome Matthew. Thanks, Matt.
So thank you very much, Ben and Carolyn. Before I begin, I would like to take a moment to acknowledge the traditional owners of the lands and pay my respects to Aboriginal elders past, present and emerging. I acknowledge that ACON as a state-based service operates all across Aboriginal land, always was and always will be. As Ben said, my name's Matthew Vaughan. I'm the Acting Director for HIV and Sexual Health, but at the time of EPIC New South Wales, I was ACON's Principal Planner working in the campaigns team, which was responsible for a large portion of the public-facing campaigns, which I'll show you today. I was going to spend the first couple of minutes talking about the successful New South Wales partnership demonstrated through EPIC New South Wales, but given Carolyn's presentation, I couldn't say it any better myself, so I won't. However, I would like to take a moment to acknowledge the leadership of the New South Wales government. It was this leadership that by then Health Minister Gillian Skinner and her staff that provided an enabling environment for the ministry and the entire sector to ask the question, what would it take to end HIV transmission in New South Wales? And this would be the early inception towards EPIC. Under this partnership, ACON was responsible for most of the community education and awareness raising to ensure that we got to our target of 3,700 at the highest risk of acquiring HIV. I think it's safe to say that by the end of 2015, there was already a community appetite for PrEP, thanks to the internet and New South Wales studies like Prelude. Following the announcement on December 1, ACON received a number of questions from gay and bisexual men. When does it start? Where can I get it? When can I get it? To assist this, ACON developed a waiting list for people to register their interest and to stay in touch with regular updates. The waiting list ended up with more than 1,500 people registering their details before the study commenced. This meant by the 1st of March, we had already had a steady supply of people waiting to enroll. This would become our first recruitment strategy, managing the waiting list with a lot of support from New South Wales Sexual Health Info Link, and of course, rapid enrolment by our clinicians helped us reach our target in record time. Under the umbrella of ending HIV, we've done about 6 campaigns specifically about PrEP, and 2 that have included PrEP in the combination approach. All in all, since the inception of PrEP, I think I've worked on about 13 different campaigns for either New South Wales, national, or in Southeast Asia. The work I'm going to show you today isn't all about campaigns. Understanding the importance of social marketing, ACON deployed a mix of community-focused campaigns, engagement events at pubs and clubs, as well as being the centerpiece for a number of Fair Day and Mardi Gras parade events. EPIC New South Wales was heavily integrated into our peer education work. Workshops for gay and bisexual men now included extensive information about PrEP. Our peer educators at ATEST, who have more than 8,000 health promotion conversations a year about PrEP, EPIC New South Wales, PEP, and U equals U. But I'll come back to that later. As I said, ACON was responsible for the creation of the promotions for EPIC New South Wales. This included everything from the participant card to the information booklet that was translated into multiple languages and posters distributed to key enrolment sites all over New South Wales. While this campaign was targeted at interested participants, this wasn't the only campaign in market. One of the things that I'd like to point out, because this was a very deliberate conversation that happened quite early, is about the language used. PrEP prevents HIV. In New South Wales, we avoided specific references to effectiveness, 97, 99% effective at preventing HIV, as we wanted this to be unambiguous. While the information about effectiveness is important, when you read it on a poster or on an advertisement where there isn't the space to explain what that really means, leaves a lot of doubt, the very opposite of what we wanted to achieve. This was our first community awareness campaign, asking the question, is PrEP for you? In New South Wales, we had the benefit of being a little bit behind what was coming out of Europe and the US. This meant that we were able to read stories about what people were loving about PrEP, and we could talk about that pleasure. We knew that PrEP was reducing fear and anxiety, knowing that it put them in control. They no longer had to worry about HIV or to try and negotiate condom use with their partners. This also countered the narrative that PrEP users were just out of control, promiscuous sluts. PrEP was keeping people in the moment. As someone who spent many years educating gay and bisexual men about the mighty condom, one of the biggest things we would hear from guys was that condoms ruined the moment. You'd be in the middle of a hot, steamy session and have to pause to put on a condom and apply the lube. While there was a lot of effort put into making condoms sexy, giving people tips and tricks for incorporating it into their bedroom, PrEP now meant you no longer had to worry about that. Finally, fuck hard. This was an advert that was only displayed in SOPVs, and it spoke to those that would be considered more sexually active, with multiple sex partners. It was giving permission, saying go for it. PrEP has got you covered, no matter how many sexual partners you have or how long you want to fuck for. For an organisation that spent the last 30 years talking about condoms and later other risk reduction strategies, this was a shift in direction. We were able to do this because we knew that we had the support of our partners, evidence from researchers, and the support of the Ministry of Health and the backing of the Health Minister. There was still some caution in the message, is PrEP for you? At this point, we knew that PrEP wouldn't be for everyone, only those at highest risk of HIV. Remember, at the time, there was still a lot of ardent condom users, and if that was working for them, then great. When I think of some of the tough campaigns I've worked on in the past, this one's at the top of the list. 2017, to coincide with Mardi Gras, our Stay Safe campaign, we now had all these options to prevent HIV, stay safe, condoms, PrEP, and undetectable viral load. We wanted to promote all of these strategies equally. We didn't want to say that one was more effective than the other, and we didn't want people to feel isolated because of their choice. The How Do You Do It campaign promoted all three of these options as highly effective at preventing HIV. And it put PrEP and UVL alongside the mighty condom and said, all of these options constitute safe sex. It was around the first quarter of the first analysis of participant data that we saw that there was an underrepresentation of Asian gay men in EPIC. With the support of Mahaz and looking at the New South Wales HIV notification data, we identified Chinese, Thai, and Vietnamese. To ensure we kept language as simple as possible, we went with the earlier EPIC New South Wales poster saying PrEP prevents HIV. I would later find out that we actually used the term AIDS in simplified Chinese, which certainly wasn't preferred. But as I said at the beginning, this isn't all about campaigns. And this is our picture of our 2016 Stay Safe campaign, promoting both condoms and PrEP. In the year of 16 and 17, we had no fewer than 16 different community forums focused on PrEP, where a panel of speakers consisting of ACON, a doctor, and a PrEP user would answer frequently asked questions about both PrEP and EPIC New South Wales. Questions about enrolment, side effects, and effectiveness. Being quite new, people had a lot of questions. These forums were held in Sydney, Parramatta, Hunter, Northern Rivers, the Illawarra, and further south. We delivered targeted community forums for young people, Asian gay men, and sexually adventurous men. Through ATEST, we enrolled over 1,100 participants in partnership with our two clinical partners, Sydney Sexual Health Clinic and RPA Sexual Health Clinic, with slightly different models at each site. Through RPA, we offer group enrollments twice weekly, consisting of 10 to 15 potential participants that would be briefed on key aspects of the study and PrEP. Following that, PrEP participants would meet with a peer one-on-one to determine eligibility and enrollment. Participants would then go on to see a doctor or a nurse for medical history, blood work, prescriptions, and the dispensing of PrEP. These clinics were highly successful at enrolling large amounts of participants into the study and were then later used to manage participation. With Sydney Sexual Health, we established an intake clinic at ATEST. This model used the existing space to have peers and nurses collaborate and enroll participants and later deliver follow-up appointments. As many of these participants were already ATEST clients, and being able to access PrEP at ATEST was important, as many enjoyed the familiarity of the space, the demand on ATEST during the years of EPIC was so great that we were booked 2 weeks in advance and needed to add additional nurse and clinic room at Oxford Street. I really want to take a moment here to thank both our clinical partners across all levels who helped us integrate peers into their clinical service models. So we've generated a lot of interest, large amounts of community demand and enrolment throughout New South Wales. And so it asks the question, how do you transfer almost 10,000 people from a well-monitored, highly targeted research study to a model that allows you to visit any doctor and collect your PrEP at your local pharmacy? The answer to that is carefully. While the PrEP listing on the PrEP was incredibly good news, it also created a lot of questions. For example, accessing the free study, people accessing the free study wanted to know when would that end? And the questions varied, that answer to that question varied wildly depending on when you enrolled. Other questions include, how do I find a doctor to prescribe PrEP? How much is this going to cost? Where can I access it? We wanted to ensure that all study participants were able to transfer from the study to accessing PrEP through the PBS without anybody being lost in the process. This campaign developed a series of short FAQ videos that delivered bite-sized information across social media. We also wanted to make sure that those that weren't enrolled in EPIC New South Wales, but still may have been interested in PrEP, were able to hear about the good news on the PBS. So aided by some strategically posted street posters and outdoor advertisements, we sought to let them know about the good news. This is my final second slide. So outside of the enrollment of almost 10,000 participants, how do we measure the success of our campaigns? Each campaign is evaluated by an independent evaluation consultant. We ask approximately 500 to 700 GBMSN a series of questions. Did you see the campaign? Where did you see it? What did you think? Did you take any further action after seeing it? And while I'd love to share you all the results of those, they're amazing, let me assure you. That would eat into Andrew's time, and considering he's the main event, I'll quickly get off. But over the years, we've asked a series of knowledge and attitudes questions that relate to the central mission of ending HIV. Questions like, everything has changed. We can now dramatically reduce HIV transmissions, which prior to launching Ending HIV in 2013, 48% of guys either agreed or strongly agreed. Now, several years later, that's 87 to 89% either agreeing or strongly agreeing. In March of 2016, when we asked, PrEP, if taken as prescribed, is an effective way at preventing HIV transmissions, 66% of guys either agreed or strongly agreed. In March 2021, 85% agreed or strongly agreed. So if I can just take a final moment to say a big thank you to all the ACON staff who worked on EPIC New South Wales, or staff and volunteers. There are too many to mention by name, but while I have the privilege to present this work today, it's actually really been a small army of people working across the organisation, many of whom are behind the scenes. But if I can draw out one name, and that's Karen Price, ACON's Deputy CEO, who was the driving force internally at ACON, pulling all the teams together. Thank you very much.
Great, thank you, Matt. So we'll move on to our third and final speaker today. So Professor Andrew Grulich is the head of the HIV Epidemiology and Prevention Program at the Kirby Institute. And along with the late Professor David Cooper, he was co-principal investigator of the EPIC New South Wales study. And he's a member of the Governing Council of the International AIDS Society. So please welcome Andrew.
Fantastic. So firstly, I too would like to acknowledge that I'm coming to you from Aboriginal land. I'm on the land of the Gadigal people of the Eora Nation, and pay my respects to elders past and present, and to particularly acknowledge any Aboriginal people who might be with us today. So after those scene-setting presentations from Karen and from Matt, it's my real pleasure to present the results of this study to you. The context has been pretty much set out for you, but just a couple of things that weren't mentioned was the fact that in preparation, as the data began to converge around PrEP being effective, New South Wales Health had arranged for statewide guidelines in 2014, which guided a demonstration project, prelude of 300 men who have sex with men. And the results of that showing excellent adherence and no adherence were really a critical foundation stone for the EPIC study. And then in 2015, I think it can't be underestimated just how energizing the results of two large studies from the UK and France, PROUD and EPIC, which both showed that oral PrEP was 86% effective in the intent to treat analyses, which was really a higher level of efficacy that had been shown in previous studies. Carolyn has explained in beautiful detail how the New South Wales HIV strategy supported this work, and that we couldn't simply keep going with business as usual. And so all of these things came together to really point towards a rapid PrEP rollout as the logical next step in HIV prevention. So the study commenced in March 2016 with the fundamental research question of whether targeted high coverage and rapid rollout of daily oral PrEP would reduce HIV incidence statewide, as well as in the cohort on PrEP. We started out, as most parts of the world have done, with highly targeted guidelines on how to use PrEP, basically consistent with the World Health Organization guidelines that you should target it towards high incidence populations with an incidence of 3% or greater. And the factors you see on your screen are ones that came out of our Healthy Men, the HIM study, which was a vaccine preparedness cohort study done in the early years of this century. The study, being a population rollout study, needed to be very pragmatic and have very simple assessments. So the inclusion criteria were really very broad, that people were at high risk according to the guidelines, they were adults, and that they were fourth generation antibody negative to start with. And they were excluded only if there was symptoms of acute HIV infection or a high suspicion of acute HIV infection and impaired renal function. So very, very broad pragmatic guidelines. We tried to ensure we had completely comprehensive ascertainment of incident HIV in the study, both at the clinics themselves. HIV was a protocol-defined serious adverse event, meaning the clinics needed to tell us urgently when that happened. And we also electronically extracted study from the clinics, including matching between the clinics. Statewide, we did seek consent from participants to link data with the HIV register, but we did not make that compulsory to participate because we didn't want people not taking up this prevention intervention simply because of privacy concerns. So about 3/4 of participants consented to that. So we don't think it's very likely that we missed HIV infections, really only if individuals stopped testing or moved out of New South Wales. As you saw from the map previously, this was truly a statewide endeavour, 30 clinics statewide. The study was done formally within a clinical trial framework. The study drug, which was initially Truvada and then changed to generic TDF-FTC, was provided at no cost to participants. And the Therapeutic Goods Administration actually only approved this PrEP as in 2016 after the start of the study, which is why we were needing it to do it in a clinical trial framework. Our Pharmaceutical Benefits Advisory Committee then 2 years later approved PrEP, and as Matt mentioned, we then transitioned people onto PBS-funded PrEP. And we ended the follow-up on March 30, 2019, which are the data I'm presenting today. Again, as has been mentioned, we had a very high and steady rate of recruitment. Our initial target was met and immediately exceeded, and that was a rapid piece of policy work from New South Wales Health there in saying, okay, our policy, our recommendations is that all people at high risk should be on this, so we mustn't let that protocol get in our way. We changed the protocol, and by study end, we had nearly 10,000 participants. It is one of the largest studies of its type globally, and as you see in that flow diagram, of the nearly 9,600 who were dispensed PrEP, we had follow-up HIV tests, or at least one, in almost 100%. Very, very limited loss to follow-up for that. We had adherence data for the first 2 years, but after people transferred to the pharmaceutical benefit system funded PrEP, we didn't have data on adherence after that point. At baseline, we had a broad range of age groups. People were overwhelmingly male, with about 1% transgender people, and mostly gay and bisexual men, reflecting the high risk groups in the New South Wales epidemic. We had a good range of country of birth. As Matt mentioned, initially we did have underrepresentation of Asian-born gay and bisexual men, but in response to the amazing work of ACON, we then did get really very good recruitment of Asian-born gay and bisexual men. We classify postcode of residence in New South Wales by a method which gives us an estimate of the proportion, are the proportion of men in each postcode who are gay. And you'll see, so 30% of those are in those very gay central Sydney suburbs where more than 20% of adult males are estimated to be gay, and about 50% in the less than 5% suburbs or in regional rural New South Wales. And a nice mix between public sexual health clinics and private general practices to reflect the real world. The results I'm about to show you are of two types: the in-cohort analyses of incidence and risk factors, and then statewide trends, where I focus on trends in recent infection, which are infections where there is evidence of infection in the last 12 months. So over this 3-year period, we had a little less than 19,000 person years of follow-up, with a median follow-up of just under 2 years per person and 30 new HIV infections. This is an HIV incidence of about 1.61 per 1,000 person years, or more than 90% less than the incidence we would have expected if the Health in Men study HIV incidence rates had applied. We looked at some fairly standard risk factors for HIV based on the limited data we were collecting. Incidence was higher at 4 per 1,000 person years in younger gay men, and it did not vary by country of birth, showing us that once people get on PrEP, it doesn't matter which country they're from, they're going to be protected from PrEP. Interestingly though, again, bisexual men from those low gay concentration suburbs were more likely to develop, were more likely to develop PrEP with an incidence of about 2 per 1,000 person years, but still very, very low rates. Men with previous sexually transmitted infections at baseline were more likely, and the more risk reported at baseline, the more risk during follow-up. But even in the very highest risk group, we're still talking about an incidence of less than 1% per year. Those groups would have had an incidence of probably 5 or 7 per 100 person years prior to PrEP. In terms of the length of follow-up, we did have up to 3 years of follow-up in this in the study, and incidence remained low, but was up to about 2 per 1,000 person years in the 3rd year of follow-up. And at the bottom of that table, you'll see mean MPR, or medication possession ratio, showing that the incidence of HIV was very, very strongly related to poor adherence. And in fact, nobody who was adherent to daily PrEP in the study seroconverted to HIV. As I've just said, so the characteristics of the seroconverters in general, all were non-adherent at the time of infection. There were really very highly varied reasons for stopping. People saying that their risk changed because they'd entered a relationship. Some people telling us they wanted to calm down, but unfortunately did go on to seroconvert. Only a couple of cases due to toxicity, the startup syndrome, where people may have nauseous or headaches during the first month and stopped PrEP. Only one case of a person who stopped because of impaired renal function, going on to seroconvert, and a range of other reasons. And only one likely resistance related to TDF-FTC, but this was likely acquired in a man who took PrEP for at least 2 months while he was HIV infected. Statewide, we saw a 40% decline by 2019 in new HIV infections, and this decline was similar in the Australian and overseas born. In terms of postcode of residence, you'll see in this figure in pink, the decline was much greater, in the order of a 70% decline in gay men resident in the gayest suburbs of Sydney, to those men living in the less than 5% suburbs who had a 14% decline, a rather small decline. Clearly, we have more work to do there. And statewide, we saw trends at most ages, but in the orangey colour, you will see that the rates of infection did not decline in men aged less than 25 years. So it was highly effective at the individual and the population level, and we do see continuing low incidence in the third of the study. Nevertheless, we do have 30 infections documented in the study in non-adherent men, with incidence a bit higher in the young, those living outside the gay suburbs, and people with multiple risk factors at baseline. So these are people that we've still got work to do. So it has been a marked decline that we've seen, but again, these relationships with place of birth do highlight areas where more work is required. To finish off with, others have highlighted the diversity of groups of people involved in this study. It truly takes more than a village. It takes at least a medium-sized town to run a study like EPIC, and as well as the Ministry of Health and the community organisations, I do want to acknowledge my site investigators, all the doctors who led the over 30 studies and contributed enormously to the study, as well as the nurses and the pharmacists at those studies. And to finish off with, I really just wanted to pay tribute to my co-principal investigator on the EPIC study, David Cooper, also my mentor, my boss, who tragically passed away early in the study. Thank you, and back to you, Ben.
Great, thanks, Andrew. So if all the speakers could share your videos now and get off mute, we'll have a bit of discussion. So we've got a few questions come through, and we already had some questions that some people had submitted prior to registering or during the registration process. So I'll just start in order of what I've received here on the screen. So would anyone like to comment about what about the risk of other STDs? Something that always comes up whenever we talk about PrEP.
I'm happy, Ben, to have first go, and just to say that we've looked at this in detail and we published on it as well. In fact, the evidence is pretty clear that STI rates do not increase in men on PrEP. And that may be surprising because we do know some risk behaviours do increase. But what we're seeing is a balance between those increased risk behaviour, but against the increased screening for STIs, which leads to earlier detection, treatment and cure of those STIs, and therefore reduced transmission. So it seems to be all in all on balance with no increase.
Okay. Would anyone else like to respond to that as well?
I think only to say this was a lot of feedback that we did get when we would promote PrEP messages out into the community. And what we would talk about is, look, PrEP isn't there to replace condoms, it's there as an added option. And you can use both together. If you are concerned about STIs, you can certainly still continue to use condoms. But for a lot of people, this was being there, put in as a way of also managing HIV risk. So it was about finding the balance. And that also was, being able to cite data that Andrew talked about also helped allay some of those fears.
We certainly have seen from other studies that we've run at the Kirby Institute sort of asking people about this. And what you typically find is this very high proportion of PrEP experienced men who say that they want to avoid STIs. But then if you ask, will you use condoms to avoid STIs? The answer is generally no. So obviously it can seem like a bit of a contradiction, but it's not really, because they're using other ways of managing their STI risk, or at least testing for STIs at an increased level, so as to control it. And we do know anecdotally, this probably comes through some qualitative research and also just anecdotally, that many men actually wanted to start getting tested for STIs even more than 3 monthly, because they were kind of really concerned about this and wanted to actually get tested, say, every 6 weekly, which is quite an interesting response, and really showing that people are taking responsibility for their health. So the next question is on whether any Asian countries in our region have considered doing something like the EPIC study, and if yes, which ones? Andrew, would you like to take that?
Look, I'm happy to. I would say I don't think any Asian countries have done a rapid targeted rollout in the way that EPIC New South Wales did, but the results of the study have been very influential in informing rollout in Asian countries. I think EPIC New South Wales was really the first population-based study to show declines at the population level, which encouraged a lot of people to say that this is worth doing. So countries such as Thailand and Vietnam are probably the two with the most advanced PrEP rollouts. They haven't been, as I said, as coordinated as being Big Bang, if you like, as EPIC New South Wales, but they are really ramping up and getting to higher levels. In other Asian countries, PrEP is still not at scale. We have small scale projects in many countries. We've very recently heard about a project which will fund up to 7,000 people on PrEP in Indonesia, people at high risk, but really it's disappointingly slow in the region and something we need to use more broadly to impact epidemics.
And I think I think it's interesting that they're, still after years and years of debate and evidence that's supporting PrEP, there's still this concern and hesitation around introducing it. So we often see, and what we see in the region and have for a number of years, are these small scale demonstration projects that include 100 to 300 people, but certainly not anything to the scale of what, like Andrew said, of EPIC New South Wales. And a lot of it has to do with the people that are in positions of power. So whether that's in government and doing we have the benefit of New South Wales, of Minister Skinner, and a really supportive minister. And it just shows where that political will isn't there, nothing happens. And so, a demonstration project will delay something or kick it down the can for later. Like, what are you looking for now? The evidence is there. It's not like the population is vastly different. Just open up already.
Yes, that's definitely true. And whenever people like Andrew or myself do presentations on this in the region, we do always talk about this, the New South Wales context being a pretty special case in some ways, where the political support was just so great. And the other thing that's quite different about the New South Wales context that I constantly get reminded of when I do these talks in other areas is the strength of our community organisations, such as ACON, and the reach that you already have and the trust that you already have in the community, which is so much bigger than most neighbours. Many people might not be aware in this seminar, but a lot of Asian countries just don't have organisations that are funded the way that our organisations are. There's not the political support for those organisations, and they often have leaders, even within those community-based organisations, who are actually anti-PrEP themselves. So you've got a pretty challenging situation, even on the community side there. So the next question comes from Curtis, and this is, I suppose, directed, I think, mostly to Carolyn and Matt. So both of you in your presentations mentioned the strength of using either a nurse-led PrEP model, or which, by extension, the nurse-led model also allowed PrEP to be delivered in the ATEST services, and how effective that was and how great that was. But this model is no longer possible because it's not being run as a trial anymore, and that's meant that so in sexual health centres, nurses can no longer prescribe, and an ATEST just can't do PrEP at all anymore. So should we be working to reinstate this?
I'll start first, Matt. Look, I mean, it's a good suggestion. I think PrEP's more widely available than it was during the study too, and with being available in PBS. In terms of prescribing, so nurse practitioners in our system can prescribe PrEP. And of course, it depends on, with those sort of nurses as well, it depends on the scope of practice. The thing that I would say, and the thing that COVID has shown, is that there are ways of changing the system rapidly that work, and where things are required at a time of need, it can be done. So what we've seen is a whole range of nurses, and actually people that aren't nurses, step up and, for example, do things like vaccines, injections in COVID. And I think what we need to do is remain open to the possibility of that, and increasing the practice of nurses is key to that, I think.
Yeah. Matt?
No, I think Carolyn gave a really good answer, and I certainly wouldn't argue. I think anything that can make accessing PrEP easier for community is really important. So whether that's being able to see a nurse and make that transition smoother, there are other countries that are looking at peer-led models for PrEP as well, and not wanting to set fire to the building, but that could be something that could also work really well here. Like, we certainly have a really well-trained peer education workforce that work in close collaboration with clinical partners. So anything, I think, really that's making PrEP more accessible would be, supported where there's an evidence. Yeah.
So I might jump to one of the ones from through the registration. So So one is from Tim, who's interested in finding about ethnicity and the country of birth of participants. I think Andrew's already talked about that. And I suppose, does anyone have anything more to say about the challenges that were faced in that area, and I guess ACON's response?
So I think in terms of challenges, one of the things that we identified from doing the Blue PrEP Prevents HIV in multiple languages was really just how ill-equipped we were to do it at that point. So while, whether that, the idea is that if you put a campaign in market, you need to be able to make sure that there's follow-up information, and as well as being able to, if people ask questions, be able to respond to those. We have the benefits or the privilege with English in that there is a lot of information that's available and accessible for people to do their own reading, but that really isn't available in other languages. So at the time, we were pulling everything together to try and give bite-sized bits of information along with Mahars. That led to what we started to do now. We're actually doing an entire website translation of ending HIV to make sure that that foundational knowledge is there across the spectrum, whether it's testing, PrEP, condoms, U equals U. And that allows us to put better campaigns or stronger campaigns into market that give that access to information. So it really is a barrier. People want to be able to read that. And that's reading it in a language that's kind of comfortable and not necessarily Google Translate where it pulls out bits and pieces.
Can I just say quickly, really congratulations to ACON for what it did, because we identified a problem in EPIC New South Wales in its early days that we weren't recruiting as well as we should in those populations. You implemented that, the rate of recruitment went up, and once the men were on study, they did not have a higher rate of infection than anybody else. So suggesting that once they were linked to clinical services, they would take Asian men, or men from non-English speaking backgrounds would take PrEP just as well as other men. So I think it was a terrific achievement from ACON, and it would be lovely to think that we could do the same thing with trying to get overseas-born gay men tested quickly when they arrive in Australia, which is one of our current gaps that we have.
So we got a few comments and questions from Yanis, our good friend from overseas, who has led quite a lot of the work in PrEP globally. So hello, Yanis, shout out to you. It's really great to see you. So he's asked, did you have any signal in your study at some point that the participants did not use PrEP as daily? So for example, on demand or the 2 T's, 2 S's approach? Andrew?
Well, we certainly did, but Ben, you're probably in a better situation than I am to answer that question, because you led the study, which was looking at the transition from PrEP on study to PrEP on PBS, which documented that. So you're probably in a better position to answer that.
Yeah, so we did ask about the way that men were taking PrEP throughout EPIC New South Wales. I think we did have a very, very small number of on-demand users. And we were quite careful, in all of our surveys, we've been quite careful how we ask about this kind of time-specific, or whatever you want to call it, type of PrEP dosing with the T's or the S's, which is where you take a certain number of pills every week, but not every day, based on the evidence that shows for men having sex with men, you only need 4 pills a week to be protected. But we were quite careful how we sort of worded that or how we promoted that, because it's not in our guidelines. It's not something that's kind of recommended here. So we didn't want to be seen as sort of promoting that strategy, but we did ask about it. We saw very low levels of that kind of time-specific way of doing PrEP, but slightly higher use of on-demand, and not so much during EPIC, but that did certainly grow in the kind of year after EPIC when we did the transition study afterwards. And it grew to kind of, it must have been slightly over 10% or so. In more recent data collection, say from the gay community periodic surveys, that's getting up to nearly around 20% of PrEP users who are now saying that they use on demand. So it's certainly growing, which certainly makes it's harder to monitor PrEP use when you've got people using really different strategies to take it. Another question from Yanis was, and so there were 30 clinics that participated, and who were the kinds of prescribers in the private clinics?
Yeah, so look, they were general practitioners from, the biggest ones were certainly in the heart of gay community, but we did have some outer suburban and even some rural places. But they were people who were somehow connected to the response. And it has been a challenge since the end of EPIC New South Wales to try to ensure we have a range of well-educated general practitioners throughout the suburbs of Sydney and throughout our regional and rural town places to ensure all gay men can access PrEP. I think it's still a bit of a challenge because we need doctors who are knowledgeable in sexual health and in gender and sexuality minorities, of whom there are just not enough such doctors. I think it's an ongoing challenge. We have some data based on prescribing data that people who start PrEP at doctors who are in the outer suburbs or country stay on PrEP with that doctor for shorter periods of time, which is concerning, frankly. And it may be a marker that some doctors don't handle it very well.
Yeah. So it is 2 o'clock. So if you have to jump off straight away, that's fine. But I just thought I might just offer everybody on the panel final last words before we end. Would anyone like to say anything more?
I'll
Carolyn?
say, yeah, I think to wrap up, I just wanted to say that the strength of the partnership and the approach for EPIC is something that's been documented along the way. I wonder whether the essence of some of the things that really worked have been documented enough. And Andrew, to your point about men that come into the country that perhaps need to be tested quicker than others, perhaps there's a piece of work in there for us to take away from this to look at what we would do from what we know and what we've practiced and what worked with EPIC to enable those men to have better access to care when they arrive. And so I think we should take that challenge on as a group, as the partnership, to look at that. Thank you.
I'll just say, you know, it was an immense privilege to work with such an amazing bunch of people and organisations in doing this study. It was truly inspiring that everybody was so excited by the possibility of what could be done. And, you know, when we hear from around the world, including from Giannis and what happened in Greece, it isn't common that you get people in political positions who are, or even in the most senior policy positions, who are as passionate about evidence-based implementation of change as we have here in New South Wales. So I can't wait for this epidemic to come more under control so that we can go a little bit back to our old epidemic and have some of that Kerry chant back to work on our existing challenges, of which there remain some considerable challenges.
Yeah, and if I can just add, you know, I think one of the benefits and what we as ACON really appreciated was being involved in the management, the day-to-day running of EPIC New South Wales. So involving communities at the very heart. So not just the appreciation or the, while I presented on the demand generation and community education, we were actually involved in the setup of the study and working with the ministry and the Kirby. And we don't see that everywhere. And that, I think that was really impactful to be involved in that. Yeah, so just want to acknowledge that involvement and participation and how much that's appreciated. And I think to the benefit of EPIC New South Wales.
Yeah, wholeheartedly agree. So thank you all. My sincere apologies to the people who asked questions that we didn't get to. Apologies for that. If you really want those questions to be answered, please feel free to email our panelists and get your answers that way. And we'll just close off by saying thank you so much to our 3 panelists for your presentations today and the great discussion. And thank you very much to everyone for your attention.
Thank you. See you later. Bye-bye.
Bye.